Hello everyone, today Roxanne and I will be discussing the radiographies of varying pneumothoraces. A PTX occurs when air leaks into the space between your lungs and chest wall. This air pushes on the outside of your lungs and makes it collapse. A PTX can be a complete lung collapse or a collapse of a partial portion of the lung. We will be discussing different variations of PTX, how it is caused and how it affects a person's body, treatment options, and show examples of a chest radiography. Now on to Roxanne in describing her PTXs.
So, I will be talking about three different types of pneumothorax. The first type is primary spontaneous pneumothorax. It sometimes happens in people who don't have other lung problems, and it is caused by the formation of small sacs of air in the lung tissues that rupture, causing air to leak into the pleural space. For the chest x ray, there is absent lung marking in the peripheral right hemithorax. A thin, dense line demarcates the pleural margin of a partially collapsed lung. There are multiple areas of atelectasis and approximately 40% volume loss involving the right lung. There is yet to be any significant shift of mediastinal structures toward the left. The left lung and pleural space appear normal. No fractures or free air in the soft tissues is seen. For the treatment, there is urgent chest tube and aspiration of pneumothorax. The second type of pneumothorax is secondary spontaneous pneumothorax. Several lung diseases may cause a collapsed lung. These include COPD, cystic fibrosis, emphysema, tuberculosis, and lung cancer. For the chest x ray, you will see that the diaphragm is up and not displaced. For the management, most patients with secondary spontaneous pneumothorax are treated with supplemental oxygen and removal of air from the pleural space, typically by chest tube thoracostomy. The third type of pneumothorax is injury-related pneumothorax. It is injury to the chest that can cause a collapsed lung. Some people experience a collapsed lung due to a fractured rib, a hard hit to the chest, or a knife or a gunshot wound. For the chest x-ray, you will see that the visible visceral pleural edge and a relatively increased transparency of the involved left hemithorax on the supine AP radiograph. This occurs as in the supine position gravity causes the lung to fall dorsally, allowing the air to collect anteromedially, laterally, and basally. For the treatment will depend on the size of your pneumothorax. If your pneumothorax is small, it may get better on its own. The goal of the treatment is to remove the air from your pleural space. When your lung is able to fill with air, you will be able to breathe easier. You may need any of the following: 1. Extra oxygen, 2. Medicines, 3. Needle aspirations, 4. Chest tube, 5. Pleurodesis.
Iatrogenic pneumothorax is a traumatic pneumothorax that results from injury to the pleura, with air introduced into the pleural space secondary to diagnostic or therapeutic medical intervention. An iatrogenic pneumothorax is a known complication of invasive procedures such as pulmonary needle biopsy, placement of a central venous line, or positive pressure ventilation. However, this condition can arise from many other procedures involving the thorax and abdomen. Iatrogenic PTX can occur with the following: incorrect placement of a nebulization kit in a spontaneously breathing intubated patient, after insertion of a hypoglossal nerve stimulator, acupuncture, and finally, the most common procedure associated with an iatrogenic pneumothorax is a subclavian insertion of a central venous line. Note the right-sided pneumothorax induced by the incorrectly positioned small bowel feeding tube in the right-sided bronchial tree. Marked depression of the right hemodiaphragm is noted, and mediastinal shift is to the left side, suggestive of tension pneumothorax. Definitive treatment options of a pneumothorax include needle aspiration, chest tube drainage, video assisted thoracic surgery, also known as VATS, and an open surgical intervention. Treatment takes precedence over imaging. If felt to be clinically unstable, the traditional first step is to perform a needle aspiration or decompression to reduce the excess air in the pleural space. Catamenial pneumothorax is defined as recurrent spontaneous pneumothorax occurring within 72 hours before or after onset of menstruation. Historically, catamenial PTX was believed to be a rare syndrome and was attributed to intrathoracic endometriosis. Even today, many years after the original description, the pathophysiology is poorly understood. A theory of catamenial pneumothorax is that it is caused by the abnormal migration of endometrial tissue from the lining of the uterus to other areas of the body, such as the diaphragm or the space in between the membranes lining the chest cavity wall and the lungs. When endometrial tissue is found outside of the uterus, the term endometriosis is used. Many women with catamenial PTX have endometriosis, which can cause small holes or openings in the diaphragm, which would allow air and fluid to pass through into the pleural space. Many women with catamenial PTX have endometrial tissue in the lungs, a condition called thoracic endometriosis. Imaging features are often identical to pneumothoraces from other causes. Rarely, small diaphragmatic defects may be encountered, representing small perforations of the diaphragm. These may also present as a nodular appearance of the diaphragm. Cases of larger perforations presenting as basal thoracic opacities have also been described. Surgery and hormonal therapy, either separately or in combination, have been used to treat women with catamenial PTX. No specific guidelines exist for the optimal treatment of this condition. Specific therapies may depend on the exact cause of pneumothorax, an individual's age and general health, personal preference, and other factors. Surgery may be performed to remove all suspected areas of endometrial tissue in the lungs and pleural space and to repair any damage or holes within the diaphragm. Surgery may also be used to remove small blisters located on the top of the lungs.
Pneumothorax can be difficult to diagnose and to treat. A person needs to work closely with their doctor to make sure the treatment is successful. Pneumothorax should not be taken lightly and may be life-threatening in other certain situations. Most cases can be treated with prompt medical intervention. Working with a doctor as soon as symptoms are noticed is the best way to ensure the pneumothorax heals correctly. Thank you for listening and watching our presentation.